am going to say is that I do think what I've found in engaging, with a generation before us is that many people were the first. They were leading work that had never been done before on so many levels. And they're brilliant and they've gotten acknowledged for their leadership and who they are. They haven't had to work in the context of building solidarity to move something forward because they haven't been in the environments that are pushing that, at least not in the years that we were growing up, let's put it that way. Maybe in the 60s, yes, but not so much in most of their career, I'm finding. So what does that mean? A lot of folks are holding on to their own ideas around theory of change as an example, how things should be. And I've tried to convene groups and getting groups to move together has taken work.
Really?
Yeah, because folks are really committed to what they know and what they want to do. And I'm like, we aren't going to go forward if we can't do that. If we cannot even do that basic part of the work of figuring out how are we aligned so that we can get to the same goal that we all have.
This is Dr. Chethan Sathya. Thank you for joining us for this episode of Northwell Health's 20-Minute Health Talk. Today, we have an incredible guest, Dr. Aletha Maybank, an executive physician and a true public health leader in this country. Dr. Maybank, thank you so much for being with us today.
Yeah, thanks for having me, Chethan. I appreciate it. It's great to be here.
We really, really appreciate having you here and have been following the incredible work you've been doing nationally and here in New York. So I wanted listeners to kind of understand a little bit more about your background.
Yeah,
right?
I appreciate that.
Tell us about your medical background. Like, how did it all start for you? How did you even think about becoming a doctor? Was that ingrained in your mind and your family?
Yeah, well, and it was ingrained in my mind, not so much through my family per se, but my mom had a strategy I learned actually later in life. But when I was 4 years old, I wanted to be a doctor ever since she bought me a Fisher-Price doctor kit.
Oh, no way.
And I thought that was just, and a lot of people had Fisher-Price doctor kits back then. And so I thought it was just part of, culture. But then she told me, I shared with somebody when they asked me what I wanted to be when I grew up, when I was 4, and I said something that she was not a fan of. So she said she went straight to the store. And for that Christmas, I got a Fisher-Price doctor kit. Yeah,
no way.
I'm dead serious.
So that's when it started.
That's really when it started. And I really did love my pediatrician as well. I remember him very well, Dr. Margolis. I can remember his name. But those two things paired together, where it was kind of my initial entree into being really clear at a young age that that's what I wanted to do. It was either that or a dancer. I grew up doing dance.
No way.
So I thought, well, maybe there was a pathway, but there clearly wasn't. So a doctor
I'm thinking about the Fisher-Price sets because that's what I just bought my daughters.
Oh,
too,
really?
And you think about those moments. But you liked your pediatrician even when you were younger?
I did. It was a remarkable
despite the
man.
Shots and all that.
Yeah, because I'm a pediatrician, so pediatricians, we're nice people. We're kind. We tend to know how to bring out the humor in a conversation and in a doctor's visit, and very gentle and kind. He was. That's what I remember, and patient. I think that always resonated with me. But yeah, I always wanted to be a physician, and I think one of the interesting things that my mom also did, I think, in recognizing that. I grew up in Harrisburg, Pennsylvania, in the suburbs in central Pennsylvania. And, it wasn't a very diverse community, but my mom was always very intentional about all the different types of people that I would be around and exposed me to many different folks. And so through church, as well as through other volunteer opportunities, what I found is I was in the homes of many folks doing many things. And I remember, for example, one woman had emphysema, and she probably was in her 60s, I'm sure. I'm young now, like 8, 9. And, I'm watching her, do her machine, change her oxygen, doing all those things at a young age while my mom's helping her. And she would let me help her change her oxygen. And my mom said, to the point where I was doing it so well, she didn't want my mom to do it. It was very interesting. But that's just an example of all the different types of it's one example of a home that I was in. And what I also learned, I think, especially I see at this point in my life, is that you cannot understand people, who they are, what they care about, what they love, who they love, unless you're really proximate and close to them. And I think that that's an important context of what this nation needs more of.
I love that.
We need to be able to be proximate. And home really creates that.
Yeah.
It builds trust. It builds, when you look around, you see how people live. So I always had an understanding that not everybody lived the way that I lived. My mom, did pretty well for a single mom in central Pennsylvania and worked very hard. But I had a lot. I had access to a lot, but she made sure I saw other folks' homes to see that
So
that was
important.
not the case.
And that connection, is so difficult nowadays, right? With social
is.
media and
I think just in a general fear of people. And I also
Conversation.
think there's a context of even the ideas of like individual houses, and not really built in the context for purpose of community and building community, not in the way that it was, in certain areas across the country, whether, I'm in Brooklyn now, right? So when you hear about the history of Bed-Stuy, community and neighborhood is very important, and the lookout for children and the growth of children. While they may have challenges, excuse me, they were still very important for having eyes, right? And we've lost a lot of that for many different reasons. And so it's just people are fearful of one another, of their communities, of their neighborhoods, what they don't know.
I agree. And I think that's across the spectrum.
That's right.
I personally feel, right, when we talk about public health, I mean, it seems like a lot of folks just have an inability to have a conversation with somebody they might even disagree with. And how do you even understand what that person's going through or why they might think the way they do and expect to build a relationship if you can't have that conversation? That's
right. As most of my career, while public health is really the through line in terms of focus and topic and scope of what I, would do as a public health leader, equity was another kind of through line and thread of it. How are we ensuring that everyone has these opportunities for optimal health within, especially the context of neighborhood? My role when I was at New York City Department of Health as deputy commissioner was overseeing, all the different neighborhoods that had the worst health outcomes. But what that really, I would say, forced me to do and forced our teams to do in a good way, and I say forced not in a negative way, but it put you in the environment directly in neighborhood to have direct conversations, not only with the people that lived there, but the business owners, the community-based organization leaders, the schools, the hospital systems. We were in community with all these folks, and not just singularly, but like collectively at many different times. And so when you're close to people, you have choices, and especially as a government coming in, it can still feel very top heavy or a power imbalance to community members. But it was our responsibility to make sure that we showed up, we were responsive, we listened, and we adjusted if we needed to adjust in the ways that we could so that we were actually being relevant to the folks' lives, and what we were saying about health. And I think that, really learning that everything is all about relationships was really foundational to my public health career.
That's incredible. How do you think we can bring that back at scale into the public health work we do, right? Which is difficult. We all, you're right, I think have to put ourselves in the positions of other people. And when you go out there in the community, I mean, every time I've done that, I've been shocked at how much I learned, how much I got wrong, how common someone else's feelings were compared to mine, right? Like I worry about safety, health of my family. Who else doesn't worry about that? They all do. Solutions might be different to get there. But when you're put under pressure in any situation, I guarantee you every single one of us in the world would feel the same way about a lot of these things, right?
That's right.
So how do you think about reinfusing that?
Well, and that's in leaving my last position at AMA as Chief Health Equity Officer and kind of experience in this work, my role was being not only a health strategist, but a cultural strategist. Like I had to look at the culture within the institution and figure out what needed to be done in order to help shift mindsets. And some people say heart sets, and I think there's an element of that as well, but mindsets to really say exactly what you just said. Where am I right? Where am I wrong? Where can I be better? How can I be better? And how can I be better with the people who are around me, right? That's the shift that we really wanted to happen. And for people to see people in a way that they may not understand, but to see that they didn't understand. Yeah. And that the goal and intention is to then sit and ask questions. Don't make assumptions. Because you can't walk in somebody else's shoes. You cannot. right? And it's like understanding that and saying, oh, what are your shoes?
Yes.
Describe them to me.
Beautifully
like,
said.
and how do you see them? How do you move through life? And it's so fundamental as that in terms of the work that I spent many years doing. And I think it's going to take several models. The scale is an interesting context, but we've seen it at scale. I mean, that's what organizing is about. My role also was an organizer, really inside of institutions. How do you get a group of people, identify what the infrastructure is per se of some of your early champions within an organization that are about this work or that are hired for this work, even better. And they have the mindsets, and then they help support people within their own divisions and bureaus to do that as well. So that's an organizing model, and that's how things go and grow and scale within an institution. That was always the goal and the intent of the work that we were doing. And then you go institution to institution, and that's how it grows. But how, we're here now at this moment in time, and I think it's what the conversations that we have with our family, the conversations that we have with our friends, and pushing each other to not walk away when moments of disagreement happen, but be able to sit there and be open and listen and understanding our way isn't always the way.
Yeah.
And you hear a lot of folks talk about solidarity. And I think it's a word that's thrown around quite often and not fully understood in terms of the give and take of what solidarity means. Because solidarity doesn't mean that you and I agree on everything, right? It doesn't mean that I'm going to get all my way or what I want. We have to find those moments and opportunities where we do align, where we do have commonality, as you mentioned before, and what can we move forward with? Understanding we probably are going to have to let go of something individually. And I've seen this play out with leaders. You're probably a little younger than me.
maybe.
A little bit. I don't know. Maybe we're the same generation. I don't know. No judgments in that way at all. But what I am going to say is that I do think what I've found in engaging, with a generation before us, is that many people were the first. They were leading work that had never been done before on so many levels. And they're brilliant, and they've gotten acknowledged for their leadership and who they are. They haven't had to work in the context of building solidarity to move something forward because they haven't been in the environments that are pushing that, at least not in the years that we were growing up. Let's put it that way. Maybe in the 60s, yes, but not so much in most of their career, I'm finding. So what does that mean? A lot of folks are holding on to their own ideas around theory of change, as an example, how things should be. And I've tried to convene groups, and getting groups to move together has taken work.
Really?
Yeah, because folks are really committed to what they know and what they want to do. And I'm like, we aren't going to go forward if we can't do that. If we cannot even do that basic part of the work of figuring out how are we aligned so that we can get to the same goal that we all have.
Those words were just so poignant. I couldn't agree more, right? How do you redefine solidarity? I mean, we both work in public health, and I think we have a genuine interest in having conversations with people that might at face value ideologically disagree with me and on a lot of things. Yeah. And I find all too often when I try to have those conversations, there tends to be a lack of acceptance for that, right? Like you're right, you're kind of excluded. Or, hey, that's not in solidarity. Like, how could you?
Right.
How could you even have those conversations?
Right.
It's a tough
it
position.
Is. And I think you have to, and this is kind of where I'm at, in my life, then you have to choose where you want to be.
Yeah.
And the reality is, and I'm talking about equity and justice now at this moment, even health more broadly, because not everybody understands health, right? And not everybody's on the same page of health, and we can come back to that. But just even as equity as a context, if folks aren't on board with it at this point in time in my career, I've used a lot of energy to kind of convince people to care about something that might be outside of their own self-interest. That's extractive.
Yeah.
It's exhausting.
Yeah.
Tired.
Yeah.
Right. And so my choice for myself is not to really do that in that way anymore. I am more interested at this point in my professional, personal life passion to work with people who also have the same agreement. Maybe not in the same way to get there. I'm okay with that, but you have to have similar values and a desire for a certain endpoint in the way that I do, and a process and a mindset that is explicit about equity and justice and all of these really important ways of being that we all want. But if you don't have that, I can't put myself in that environment anymore.
Yeah.
It's hard, but everybody has that choice, because I think people need to stay inside the institution too.
Yeah.
As I was, right?
Yeah.
And I think you have to choose where you want to be, especially at this moment of time.
Yeah.
That is right for you.
Yeah. Yeah. And I think, just hearing what you're saying, I mean, questioning things or listening to alternate opinions, I don't think negates the great things that have happened.
No.
And it doesn't mean you're against certain types of work or so on. And I think you probably had to navigate a lot of touchy conversations right through the years.
Oh, yes.
Why don't you take us through, so you mentioned you were the Chief Health Equity Officer at the AMA, the first named?
Well, right. So there are many people, I don't want to take away from all the folks who've been doing equity work. I mean, I was an equity leader prior to going to AMA. But also disparities, or the 3-letter word of acronym rather of DEI, right? And we can talk about those distinctions too. But when I went to AMA, it was one of the first named chief health equity officers in the nation, overseeing a national role. There may have been one other at a health system, and I believe it was in California, but this was really one of the first named chief health equity officers. And it was before COVID, right? And right then, as COVID launched, there was the public murder of George Floyd as well. And you saw then this kind of explosion of chief health equity officer positions across the country in all aspects of the ecosystem. And what the chief part did, was bring the intentionality, hopefully the accountability, because that's the really important part of the work, to the highest level of the organization. Hopefully also bringing resources to actually do that work and to be able to build the teams and do the work that needed to be done within an institution as well as external institution. And I would say most of the roles, though, were probably external to the institution across the country. But when I was at the New York City Department of Health working with Dr. Bassett, who was commissioner, we really knew that we had to have an internal-external focus, even as a health equity. I'm not a DEI professional. I tell folks, DEI historically was an HR role, like human resources. It was about workforce. And there's a lot of I don't want to take away from all the expertise that understanding workforce and all the stats and evidence that what it means to have a diverse workforce that's working in an environment that's equitable. I needed to have knowledge. I needed to be able to help support human resources leaders or finance leaders or whomever else was doing administration within the organization. But that wasn't my role. My role was helping to support building that institutional infrastructure that would get us there across, whether it was communications again, HR, whatever it was, that they started to build in a health equity mindset, and then therefore frameworks and structures so that they could hold themselves accountable to doing this work. And, thankfully leaders, Dr. Bassett, and when I was at AMA, there was levels of accountability as well through either the House of Delegates or, the CEO at that time too. So, it was the first bring it into the C-suite in that way. And, unfortunately, it's 6 years I was there. Not unfortunately 6 years I was there. I was there for 6 years. And unfortunately now, what we see is an absolute regression across the country. For holding and naming these roles. What I did learn is this power, again, that I can capitalize more so being outside of institution this way, but the power of narrative, the power of story, and actually changing and inspiring people's will. What I've learned in my work is that numbers do not change people's wills. Numbers are important for accountability. They're important for tracking things over time or an understanding baseline, but they don't tend to inspire people to feel differently, to act differently, to be challenged, to be curious. It's the context of story and that connection of emotion, understanding or projecting that, that person's experience may be my experience, Or, wow, I've never heard that experience, and something just hits you emotionally. That's where I've seen leaders change. And that's what I leveraged over my career.
Yeah, what would you say to folks who, don't agree or who are disgruntled with the idea of health equity and might have misconceptions around it, right? Because I think there's also the other narrative, which is that maybe health equity is not necessarily health for all. There are other forgotten communities across the country. I do hear that in conversations around people saying that. Of course, there's the whole meritocracy, discussion as well, but that's more on the workforce side, right? So we can leave that aside. But yeah, what would you, how do you address that? Because I'm sure you're interacting with that daily.
Absolutely. And I think the country's interacting with it daily, right? I think for health equity, I break it down. It's pretty simple. And I say, this isn't the rocket science part of medicine, really. It's not. And health equity, in its simplest term, as I mentioned before, is optimal health opportunities. So making sure you have the power, the conditions, and the resources in order to achieve optimal health. That's it.
Yeah.
If you as a health leader think that is a bad thing for people to have or pursue, to me, that's a problem.
Yeah.
But it's as basic as it doesn't make sense. And I think sometimes you have to make it as basic as that. What are you saying really when you're saying, I don't want health equity? And part of it, and I'm not going to blame the folks who don't fully know or understand, because what has happened over time is that words do become jargon. They become poorly understood, poorly defined. There are many different, definitions. But the context of desiring that all folks have dignity and opportunities, resources, and power to achieve optimal health, I think what you said earlier, it's a basic human condition and desire.
Yeah.
Everybody wants that. And so the way you go about it now, and that's where people start, I think, having more of the problem, because then when you start to look at the data, not so much on the health side, but again, this still should be of interest to people on the health side. When you look at the data across the country, across cities, within cities, and you see that there are different outcomes, we need to be curious as to why. That makes sense as well to some level. And then when you look at the reasons why, I think for years, we kind of looked at the superficial reasons, right? The behaviors, behaviors, basically, people were doing these, and oftentimes it was a blaming behavior, or it was a kind of, well, those folks aren't working hard enough and they're not doing enough in order to take care of themselves, aligned with the meritocracy kind of piece of it, right? Or sentiments and notions of, well, that person's taking from me, so that's why I don't have. And so all of these kind of dominant, not helpful, malignant narratives are in the soup here and become very confusing for folks.
Yeah.
Because they're not really understanding the root causes of why these differences exist. And oftentimes it has been as a result of, I'm going to use structures, so laws and policies, that have been created and put in place that create the conditions of which people live in, right? And oftentimes there are lenses of which many laws and structures are put in place. And most folks who are doing laws and policy in this country are still pretty privileged people. And when you look at the number of folks, look at Congress, it's still a predominantly white male institution.
Yes. Yep. And
the lens of how things are structured and set up are going to be from their lens. In one level, it makes sense, right? If I were to do something, well, maybe not Aletha Maybank, because I know the processes, in which you gather other input and ideas and you listen to people and you sit with them. But oftentimes the way things are done are the way they're doing them in their own interests. And that's how our systems have been designed and structured across the board.
Yep.
And so that impacts people's health.
Yeah.
Politics impacts people's health. We're hearing it more and more. I think that's one of the advantages of this time, is that social media is helping this, but I think a lot of folks are starting to develop a greater critical consciousness as to the why, right? And seeing that politics actually does influence your health. That health is very political.
Yeah.
You can't separate from that. I was at the AMA,
Yeah.
It is about politics. It's a lobbying organization that is speaking directly to politicians. All of them are.
Yeah.
All of organized medicine does. So of course it's political.
Yeah.
So to deny that, it's really
it's
tough.
kind of a counterfactual.
Yeah. It's it's odd a little bit.
Yeah.
And so, again, that critical consciousness amongst health leaders, amongst the entirety of the American populace is really important.
It's important. So what do you think we got wrong then when it came to the messaging around, as you mentioned, even the term equity, right? Because it does become jargon.
Yeah.
And there are certain communities maybe that feel forgotten by that, right? Or they feel as though maybe the investments into these initiatives didn't actually lead to improved outcomes. I don't know what the answer is, but what do you think we got wrong?
Yeah, so a couple of things. I try not to say too much what we got wrong.
Yeah.
Because I think that's unfair.
Yeah.
One, because how long has this nation been in existence?
Not that long. Yeah.
Not that long and longer
Yeah.
than when I started this work in 2006, but equity work started, let's say, let's take Secretary Margaret Heckler's report in the 1980s. We'll say that. Let's just say that, right? That's 40 years ago now? I can't count. 45 years ago, right?
45,
or so. And so if that's the length of time that we've been doing explicit kind of health equity work or health disparities work, that is a very unfair difference compared to how long this country has been here versus the time we've actually have intentional, at least understanding that these disparities exist. There was understanding even before that, because credit to W.E.B. Du Bois of the early 1900s, late 1800s, early 1900s, who did the amazing report on the Philadelphia Negro, looking at the health and just conditions of the ex-slave within Philadelphia. Great report. Showed that there are differences in health related to the context of the neighborhoods that they lived in and related to the context of race and racism. So he was one of the first. But then I would say our nation really, really came back to it in some parts during Reconstruction period as well, but really during the 80s when the federal government started to take initiative around this and put funding towards it. But that was a very small, period of time. And so I think it's really unfair to expect us to have a commonality of an understanding of the causes of disparities. That's taken us some time to really get there and to build a greater consensus. And we don't still have full consensus around that because we see all that's happening.
Yeah.
But that takes time. Also, I just from a moral perspective, I would say what we are doing is not wrong.
Yeah, absolutely.
Their mindsets are not wrong. The
Absolutely.
belief that people should have optimal care, dignity, is not a wrong thing. And I don't feel it's evil in any context. I don't think we're trying to take anyone out of the equation. And so I really, when I started to hear that context, well, this is what health equity did wrong. I'm like, that's not fully fair, in the context. The one thing that I will say at this point is I don't think part of our narrative was strong enough and actions as it related to accountability. It's really Dr. Bassett that I learned a lot about accountability. And she said that, she was deputy commissioner before she became commissioner. She came back as commissioner. And one of the things that she said to me as we were beginning to lead this work, she realized that people weren't just going to do it naturally. So she could say, hey, there are differences there, in that neighborhood, we need to really focus on it. But she couldn't, but she realized if there wasn't greater accountability, so what are you going to do within your teams to do something about it? People didn't do anything. So she realized when she came back as commissioner, not only was there kind of the goal and the mission and, the strategies that we would employ to pursue equity, but how are we going to hold the teams and the leaders accountable to that work as well, and her role in doing that as the leader. And then at that time, we had the mayors. Ever since that time, we've been in a city that really does explicitly talk about
For
equity.
Sure.
That's one of our great advantages and hopes in New York City, right?
Yeah.
That we haven't shied around this context of equity in these last couple of years. So this accountability piece is really critical. And I think we as health equity didn't fully say, we are here to hold accountability to the civil rights law directly, because that's what we're here.
Yeah.
That was, that was really the context of most equity work, even DEI work, is the civil rights legislation that was passed. And we are the people who are hired to do that. But we didn't connect that dot. So if those dots. And so if you have like hospital systems and you hear women are dying at certain rates, and over and over again at certain hospitals, why aren't we holding them legally accountable more often to this harm that's being caused? I think that's
interesting. Yeah.
There are many, and that's just one example, because I want to keep it simple so that folks understand. But we didn't leverage the law well enough. And now we're in a time when it's really hard to leverage the laws in the way, even though DEI is still legal and doing the work in that context, and health equity work is still legal. People are still shying away from it, but it's harder to, pursue something legally in the way that it probably was before.
Interesting. Yeah, no, that definitely resonates. And I also love the way that you reframed kind of the time frame, right? Because it's so easy to look at times now and feel like, progress hasn't been made.
Right.
But the truth is, to your point too, the time frame hasn't been that long. And I would argue, right, others have made incredible progress.
Exactly. I mean, just incredible progress. I think the fact that even folks, and I think COVID did this, and the public murder of George Floyd, but especially COVID, that equity, the word of it, the health equity, this consciousness that, communities have different health outcomes, I think was a huge success of COVID, right? Where before, I joke around where my mother would say she has no clue what I do, because I'm not seeing patients in this equity work. But then she during COVID, when she started to hear, the news was reporting on the inequities and all these things that were happening across the country. And she said, for the first time, I finally get what you do. I started to understand what the work is. So it's in public narrative in the way that it hadn't been before, which is really important to evolving narratives.
I love that. So Dr. Maybank, we could chat for hours. We are almost at time. So I did want to give you an opportunity to quickly talk about as well, your new work when it comes to culture, film, right? You're doing some incredible stuff.
Yeah, so I'm not in an institution per se. I don't feel I can go back full time. But what I did learn is this power, again, that I can capitalize more so being outside of institution this way, but the power of narrative, the power of story, and actually changing and inspiring people's will. What I've learned in my work is that numbers do not change people's wills. Numbers are important for accountability. They're important for tracking things over time or an understanding baseline, but they don't tend to inspire people to feel differently, to act differently, to be challenged, to be curious. It's the context of story and that connection of emotion, understanding or projecting that, that person's experience may be my experience, or, wow, I've never heard that experience, and something just hits you emotionally. That's where I've seen leaders change. And that's what I leveraged over my career. And so that, to me, one of the best vehicles to do that is through film. And I think marketing in health is challenged for many reasons. $1 just aren't there. You need a lot of dollars to do really good, savvy marketing. Social media has been leveraged by some, and we see that, but not enough. And you have to have intentionality around doing it. And so I think that film is another way to kind of bring that into the ecosystem. So I launched Truth Light in order to do that and to help really expand this narrative of health, that health is not just healthcare. So if you look, this is a good question for you. What do all shows on TV, where do they exist that are related to health? Where are they happening? This is a trick question for you.
Yeah, I figured.
It's really not a trick question for you. In the ER.
Yes.
If you think about all the TV shows, they're either in the ER or the surgical space.
Yeah. ER,
right?
Surgical trauma.
Right.
Yeah.
And so that's a reflection of two things. It's culture influences policy in health, right, as well, or policy in general. But it influences what people show and produce. And so most of America's mindset around health is around healthcare. They think about healthcare. They do not think about transportation or housing or politics for that nature, translating to impacting their health. And so the goal is also expanding this narrative that really that all policy is health policy, and that everything really has impacts as it relates to health. And so that's the goal with the film company, expand the narrative of health. It will be helpful even in having equity conversations because it's so historical. It was really a barrier to some point of talking about health equity because people didn't even understand the full context of what influences health. So that's another thing that I recognize, that I just feel it's really important to do more to expand this narrative of health, not only through film, visual culture, but also policy as well.
I love that. And just, full circle to your initial comments, right, about having those conversations, integrating those stories into health education for people across the country. Right. I think you can entirely change the narrative. Dr. Maybank, thank you so much for being with us. We look forward to checking out, what all the amazing things that will come from that and all the initiatives you have. Thank you for being with us.
Oh, thanks for having me. I really appreciate it.
Thank you for joining us today. This is Dr. Chethan Sathya for this episode of Northwell Health's 20-Minute Health Talk.